The next speaker is Maylin Bissonnette. So she is a clinical associate professor in the Department of Pathology and Laboratory Medicine at UBC, and also a director of she's the director of the BC Provincial Renal Pathology Laboratory. Her training is in her bachelor's is in biophysics from Johns Hopkins University, MD PhD from Northwestern University in Chicago, and residency and fellowship also at the University of Chicago. So we'll let Maylin talk about microangiopathy. Okay, go ahead.
Thank you very much, and thank you to Hugh and all the organizers for the symposium for inviting me here today. So I'm one of the medical renal pathologists for the province of BC, and we're a centralized service, so all the kidney biopsies that come for non-tumors come and are read at St. Paul's Hospital. So I see a multitude of diseases that affect the kidney. I'd read everything except for kidney tumors themselves. And so I really appreciate opportunities such as this. I normally work day-to-day with nephrology, but it's really great to be able to see research and see colleagues that cover diseases where we have a lot of common interests. So thank you. And so my conflict of interests. And so in the kidney, it's a highly vascular end organ. And so its main function is blood filtration and the production of urine. So there's a very vast and rich vascular network that's associated with all the nephrons. So with the arteries flowing in, down to the arcuate artery, which you can see at this very low power view, to the intralobular arteries, which are a little bit smaller, more difficult to see, and then down to the glomerular capillaries, which are these bundles right in here, but you can see better here in the schematic. And so at a higher power, you can see again the glomerulus here with all of its capillaries, and this is where the filtration system actually happens with the slit diaphragms, but there's also the intralobular arteries, the arterioles, and you can start to also see at this high power magnification also the peritubular capillaries. So it's a very rich vascular network with a lot of endothelial cells. So this is a CD31 stain to highlight the extent of the endothelial cells that we see. And so with this vast amount of endothelial cells, there's a lot of disorders and diseases of both the endothelium as well as the vasculature that we see on a regular basis. And so one of the main ones that we see is thrombotic microangiopathy. So it's endothelial cell injury that's associated with platelet activation and consumption. And so hopefully my goal today is to take a lot of the lab medicine and research that have been presented today and demonstrate the injury effects on the tissue. And this results in thrombi within the microvasculature, which can then cause a lot of shearing with the red cells and ultimately leads to tissue ischemia, and that's predominantly what we see in the kidney. And clinically, what we see is thrombocytopenia due to the platelet activation and consumption, and due to the red cell fragmentation, we see microangiopathic hemolytic anemia, or MAHA, with the schistocytes, low haptoglobin, elevated LDH, and elevated indirect bilirubin. So that's what's seen systemically, but particularly to the kidney, the results of the endothelial injury, particularly in the glomeruli, results in hematuria, proteinuria, as well as hypertension. And so this can cause a lot of damage within the kidney itself. Excuse me. Hemoglobin myoglobin is very toxic to the tubules, as is proteinuria. And it's well known in the kidney literature that regardless of disease, with high levels of persistent proteinuria, it really causes long-term kidney damage and will eventually lead to transplant. But when it comes to thrombotic microangiopathy, the systemic findings are not required. We often have renal-limited TMA, where the patients just have hematuria, proteinuria, and hypertension. And these three findings are not unique to TMA. It's basically every disease that you can see that affects the kidney will present this way. And so really the only way to diagnose thrombotic microangiopathy affecting the kidney is through kidney biopsy. And there's a lot of etiologies that can cause thrombotic microangiopathy. So the classic is TTP as well as hemolytic uremic syndrome, that's bacterial mediated, but we see a vast array. Infection-associated TMA, complement-mediated associated TMA, drug-induced TMA, and a lot of these are not independent. So when you have like, say, transplant-associated thrombotic microangiopathy, it could be drug-induced due to calcineurin inhibitor toxicity. It could be due to antibody-mediated rejection. It could be due to de novo disease, recurrent disease. There's a vast array that it could be. It could be complement-mediated TMA, but just in the context of a transplant. And so it can get very complex, but it's very important to determine the underlying etiology, because for all of these, the findings in the kidney look exactly the same. The form of endothelial injury that we see is all the same. So we make the diagnosis of TMA, but reality, it's a diagnostic pattern, and we work very closely with hematology, nephrology, and a lot of others to really determine the underlying cause, because that's truly the only way to effectively treat the patient. So I'm going to present a case that highlights this. So when I was preparing this talk, of course, I ended up in the span of about 4 weeks with 4 very complex, very difficult cases of TMA, all very interesting and all with different underlying etiologies. And so this is a case of a 64-year-old woman. She was diagnosed with a metastatic, very aggressive ovarian cancer in 2016 when she was living in Iran. And there she had multiple surgeries, but also multiple relapses, and she underwent multiple chemotherapy regimens. So she went through 3 different lines of chemo. Listed below are the different agents used, different combinations, and different amounts of each. She did move to Canada in 2024, and there she was started on her 4th line of chemotherapy, which was a single agent for carboplatin. But unfortunately, that had to be discontinued due to hypersensitivity reaction. So in February of this year, she started now 5th line chemotherapy that included doxorubicin as well as bevacizumab. So prior to biopsy, cycles 6 through 9 were held due to the slow rise in proteinuria. And so looking at her lab values, so when she first presented in Canada, her baseline kidney function, her baseline GFR was 60 to 70 mils per minute, which normal, like all of us today here, probably around 100, 120. So she was already starting with lower kidney function, but given her past history and her cycles of chemotherapy, quite reasonably good. So she started her 5th line agent in February. In March, it went down to 50, then in June down to 40, August down to 30, and in October, just prior to biopsy, she was down to 22. So a slow, steady decline in kidney function. She also, while this was happening, there was also a slow rise in proteinuria. At the time of biopsy, she was about 3.8 grams per day, so that's nephrotic range, as well as hematuria. But when all of this was going on, her platelets, you can see, were always within the normal range. Peripheral smear had multiple done throughout this time, no specific changes. Haptoglobin was normal, LDH was normal, and bilirubin was also normal. So nephrology biopsied her because of the main question of what's the cause of the proteinuria. So bevacizumab is known to cause a lot of nephrotoxicities. One of them is causing a secondary focal segmental glomerulosclerosis, resulting in the nephrotic range proteinuria, but it's also well known to cause thrombotic microangiopathy. And the only way to distinguish that is through biopsy. So taking you through the findings. So first, because I'm assuming I'm the only renal pathologist here, there's a normal glomerulus. And you can see that there's the capillary loops, which are very thin and delicate. It's very acellular. There are mesangial cells, endothelial cells, as well as podocytes, but it's very difficult to tell which compartment each cell is in. And these are all of her glomeruli. So every single one, I believe there were about 20 or 25 sampled, and each showed these very severe findings, where you can see that now the mesangium is very expanded. But it's not just expanded with matrix in a scarring type of way, but it's very thin and delicate expansion, and so it's mesangiolysis. So there's actually damage and lysis to the mesangial matrix itself, as well as damage to the subendothelial space. This is likely an endothelial cell, and then here, due to damage, you have this widening of this, again, thin, lucent material. And this is with the Jones stain. That's a silver stain, so you can see it a bit better. And here is a capillary loop where there's duplication of the glomerular basement membranes. So anytime the endothelium is damaged, the initial injury is that lucency and lysis of the matrix that forms the glomerular basement membrane. But the endothelial cell, which in part with the podocyte makes the glomerular basement membrane, will try to lay down another layer to cause it to repair it. So you see frequent duplication of the glomerular basement membranes, as well as right down here in one glomerulus at the very edge, there was a fibrin thrombus sitting right within one of the capillary loops. And so on electron microscopy, normally these are the podocyte foot processes with their slit diaphragm, glomerular basement membrane. The endothelial cells have fenestrations. And between the two, this is the filtration barrier, both by size and by charge, for making urine into the urinary space. And so this is the patient's glomerulus. So here's a mesangial area. This one's a bit more normal, but you can see it's very electron lucent with a lot of interposition of cellular debris, as well as the endothelium here, whereas you can see that there are the little fenestrations in the normal endothelium. Here it's basically one continuous large cytoplasm associated with, again, the injury with the lucency, laying down a secondary basement membrane, and that lucency then extends down into the mesangium with the mesangiolysis. And some areas were extremely severe. So this is the lumen, whereas normally this is what the GBM looks like. Again, you have this large expansile area with very severe damage. But unlike in the glomeruli, the endothelium of the arteries and arterioles were completely intact. So here's a glomerulus with global mesangiolysis, and then here is one of the arteries. You can see the endothelium here. Very thin, very indiscernible cytoplasm, uninjured. And there was no intimal proliferation or mucoid intimal change, which is the equivalent change that we see that, in the larger arteries to what was seen in the glomeruli. So I mentioned so when it comes to the pathologic features of thrombotic microangiopathy, as I mentioned, it's a combination of features that exist regardless of the etiology. So there's active lesions as well as chronic lesions, and it's really to know how far gone the kidney is to see how much function the patient will get back. So duplication in the glomerular basement membranes can't be changed, and that's permanent proteinuria, which will be an ongoing issue for the patient. So the active lesions include the endothelial swelling, fibrin or platelet thrombi in glomerular capillaries or other vessels, the bloodless appearance to the glomeruli because of the damage to the glomerular basement membranes. The red cells aren't very perceptible. Mesangiolysis, red cell fragments in the mesangium, so sometimes it is hemolytic, and mucoid intimal change and intimal proliferation by foamy macrophages. So an example of that, so this is another patient that I also recently had right before this other case of a patient with lupus, antiphospholipid antibody negative, but presented with malignant hypertension because of her lupus vasculopathy, and then a really terrible TMA within the larger vessels. And so here is an arteriole, and normally the endothelial cell layer would be right here, but that right there, that single red cell, that's the lumen. So this is all mucoid intimal change. And this is a case in a transplant patient where there is a large fibrin thrombus within the interlobular artery. And so in terms of chronicity, so there's duplication of the glomerular basement membranes. If you damage the GBM, the endothelium will try to repair it and cause a second layer. Ischemic glomeruli, because of chronic narrowing of the lumen, will result eventually in ischemia, and eventually that will lead to global as well as segmental sclerosis. So scar in the kidney, that's function that will never return. as well as interstitial fibrosis and tubular atrophy. So once you scar down your glomeruli, the interstitium will also scar. And again, that's kidney function that will never return. And layering of the intima. So that's either in terms of atherosclerosis in the larger vessels, or in the smaller vessels, it's what's called the onion skin appearance, where there's the layers of the intima. And so this is the same lupus patient, so there were very active lesions as well as chronic, and here's a larger artery, and you can see that there is the layering of the intima. This one's more active. And then again, this is the onion skinning appearance, where you can see the multi-layers within the arterioles. And so this patient was previously on bevacizumab, and so that's a VEGF inhibitor. And drug-induced thrombotic microangiopathy makes up about 10 to 13% of all TMAs, or about 20 to 30% of secondary TMAs. And we see it not uncommonly in the context of patients who are receiving various checkpoint inhibitors, VEGF inhibitors, and tyrosine kinase inhibitors. And so in terms of secondary, in terms of non-genetic causes of TMA, secondary causes are 90% of all TMAs. And drug-induced TMA is the third most common cause of secondary TMA. So VEGF inhibitors are extremely important. So VEGF is a growth factor that's essential for angiogenesis. And so this fact is used in the context of cancer therapy in order to decrease tumor growth, and it's very effective. But it is a known nephrotoxin. And in different studies, there's been a range reported, but proteinuria is present in 21 to 62% of patients in various studies. And again, long-term proteinuria over a gram a day, and this patient had 3.8 a day. It's known to have long-term detrimental effects for patients. And in the largest biopsy series, although it's probably a bit biased because you can only diagnose TMA on biopsy, 66 of the 67 patients who were biopsied, who are taking bevacizumab, did have a kidney TMA, as well as more than 80% with hypertension. So VEGF inhibitor-associated TMA is a very special case of drug-associated TMA because it's always renal limited. And that's because the podocytes produce VEGF. So again, here's the glomerular basement membranes, the podocyte foot processes, and then the endothelial cells with their fenestrations. So the podocytes produce VEGF. And the endothelial cells express tyrosine kinase receptors, VEGFR1 and VEGFR2, on the glomerular endothelial cells. So there were some very elegant studies where they looked at time knockout of podocyte VEGF, so not systemic VEGF, but only in the podocytes within a mouse model. And 4 weeks post-induction, they showed the same histologic features of TMA that I showed that this patient had, again, glomerular only. And they developed hypertension and proteinuria, just like human patients. And interestingly, they administered extrarenal human VEGF to these mice, but it did not reduce the kidney injury, nor did it prevent the continuation of the TMA. And so VEGF in this context induces the formation of these fenestrations of the glomerular endothelium, and that's what's required for the filtration barrier for how the glomerulus works. And the loss of VEGF leads to the loss of these fenestrations, and so this results in a microvascular injury, which then leads to the TMA. And so, the blood, so when it comes to the filtration barrier, the blood flows, but then the filtration goes from the endothelial cell layer towards the podocytes. So the VEGF actually, interestingly, goes against the flow, but it's small enough, so it's 26 angstroms, and about 30 angstroms is the maximum size, so it can actually diffuse against the filtration barrier flow. And so this is just an example, then, kind of a breakdown of how it would all work. In normal cells, you've got the podocytes making VEGF, which then crosses the filtration barrier, binds to the endothelial cells, and everything is healthy. In the VEGF knockout, it ends up with endothelial injury, which is the same result as the VEGF inhibitor that binds to the VEGF on the endothelial side. And so, but that's not just the end of it, because, so in this case, for this patient, they hadn't given the drug for about 4 months before the time of biopsy. But you can see from what I showed you, she did have some chronicity, but there were still diffuse and very severe active findings. And so subsequent to those studies, other studies have shown the effect of complement in this process as well, where, like what we see in complement-mediated hemolytic uremic syndrome, when the glomerular endothelial cells in the context of a VEGF inhibitor are injured, there is a decrease in factor H, as well as an increase in C3b, as well as then an increase in the amount of the membrane attack complex. And so there really isn't, unfortunately, much that can be done in the context of drug-induced thrombotic microangiopathy other than to remove the drug. And if that doesn't work, as in this case, really the only possible thing is to look at inhibiting the complement cascade. And at this point, all we have is eculizumab. And so for this patient, they were putting in for an emergency trial of eculizumab. And so with that, I'll take any questions.
Great talk, Mary. So in terms of the drug-induced TMAs, or the drug-induced what looks like a TMA, how systematically have people looked at using eculizumab when, without other evidence?
So there's not a lot of evidence, unfortunately. There hasn't been these big clinical trials, which is really needed. And I think it's just because there's not a lot of patients per center that do have a drug-induced TMA. So it's very difficult. There's lots of published case reports, but in terms of overall efficacy, there really isn't much. And determining if there truly is a deficiency in complement is extremely difficult because, in all of these cases, in all the cases that I've had, we send away for the complement gene testing as well as activity at University of Iowa. But that testing has its limitations, and it can only tell us so much. So the absence of findings doesn't mean that there isn't some deficiency in complement. And even just with the trial of eculizumab, if it works, then it's great. But the complement cascade is complex enough that eculizumab doesn't cover all the points of deficiency and issue, unfortunately.
Can I just ask a second question? In terms of the reversibility, somebody who has a severe kidney damage with frank thrombosis and fibrin generation, how reversible is that in terms if it's a real complement-mediated TMA?
So, unfortunately, like when I say activity and chronicity, so the chronicity doesn't necessarily have to need a long time to develop. It could develop in days, weeks, unfortunately. And those chronic features that I showed are not reversible. But the actual fibrin thrombi themselves, those, if they're removed, as long as it's not causing the multi-layering from the endothelial damage, that will stay, but everything else can resolve. So the mesangiolisis, that can resolve. But the GBM subendothelial widening, that will turn into duplication, unfortunately.
Yeah, great talk. You mentioned that regardless of the etiology of the TMA, that the pathologic, histologic features look similar. But for some reason, I had the understanding that with TTP, the endothelium is relatively spared, whereas a lot of the other etiologies, you have endothelial injury, that's part of the TMA process, whereas with TTP, it's more just that intravascular von Willebrand's ADAMTS13 deficiency phenomenon, so the endothelium's relatively spared. Do I have that wrong, or have you seen kidney biopsies in TTP cases?
So I haven't seen that many, but it is interesting that, we always think of endothelial injury then leading to the thrombosis. But actually, in terms of the kidney, you can also have a thrombosis that because it's present and it's adhering, it then results in endothelial injury, so you can still get the same features. So sometimes it's which one came first, and it can be a bit difficult.
Chicken and egg. Thanks.
Your very nice presentation. Thank you. So regarding this TMA, to follow this question, is this platelet rich or fibrin rich? So that's probably not only related with etiology, but also could related with how to handle these patients, how to treat them, right? If it's von Willebrand factor rich, so then probably recombinant ADAM13 able to be useful. If has to fibrin is dominant, so TPA, TNK, and other the anti, fibrin or fibrinolytical reagents should be considered. So do you have some comments about it?
Absolutely. So there's, the pathologic findings are very similar, but there are small, fine differences between them. Like in malignant hypertension, we'll tend to see it in the larger vessels. Like in this case, it's in the glomerular capillaries. And it's also the case with the quality of the thrombi. So in this case, it was a platelet thrombus. Platelet thrombi have a distinct morphology. We can also stain them for CD61 if there's a question. Fibrin thrombi have a different color and a different consistency, and we do sometimes will see the red cell fragments, and that is something that I always convey when discussing these results. If there's anything hemolytic or to suggest that it's hemolytic, I will make mention of that. And in terms of staining for fibrin, so depending on how frequent the thrombi are and the distribution, because I didn't show the immunofluorescence because in this case it was negative, but we do, per routine, for the native panel, include fibrinogen.
Thank you.
Okay, thank you.